Sanket Mehta. Dr. Mehta is a renowned surgical oncologist and a pioneer in peritoneal surface oncology. He serves as a president of Society of Peritoneal Surface Oncology of India and brings unparalleled expertise, having performed over 1,000 cytoreductive surgeries and 700 plus HIPEC procedures. Notably, Dr. Mehta introduced PPAC therapy to India, significantly advancing cancer surgery techniques. Before we begin, here are few housekeeping rules. We encourage questions. Use the chat box to submit your queries at any time. Dr. Mehta will address them during the question answer session at the end. Without further ado, let me give a very warm welcome to Dr. Mehta. Over to you, sir.
Thanks, Ritu. Thanks for the very kind introduction. I noticed that you didn't mention anything about liver surgery, so you probably got hold of my very old biodata. Okay, but that's fine. So I think we know a lot of people in the attendees list, so I'm sure everybody is aware. So this is the first of the five-part series that I thought would make sense for both beginners and people who are regularly using ultrasound alike, just as a revision perhaps for those who are already using it. But for the rest, I think it's a worthwhile starting point of how to address intraoperative ultrasound. I will start. Is my screen visible?
Yes, sir, it's visible.
So the first in the series of talks is about the basics of intraoperative ultrasound. And I think this talk is very, very relevant to understand the fundamental principles of intraoperative ultrasound, to see the evolution from the traditional surgery to the ultrasound guided surgery, to appreciate the clinical impact on surgical decision making. And I think that's where people will see value of the intraoperative ultrasound. And this talk is essentially a very basic talk for which lays down the foundation for advanced techniques in the subsequent sessions. But none of this would be relevant without a little bit of the background history of how intraoperative ultrasound has evolved in the field of liver surgery. So intraoperative ultrasound actually came into liver surgery in the A mode setting, which was like the pulse setting, a single image being produced. And it was essentially used in the early 70s for diagnosing renal and biliary calculi. Subsequently, the M mode was introduced in the cardiac surgery, which led to the development of the B mode, which is a 2D real-time imaging, which can be utilized for liver imaging. And then the pioneering work of intraoperative ultrasound was actually done by Professor Makuchi from Tokyo, Japan. And this was done in the 80s. He is singularly responsible for a lot of innovations that we see today, including the linear array probe, which he was involved in designing along with Hitachi Aloka, which is now Fujifilm, of course, in 1979. It was an I-shaped probe with just one frequency of 3.5 megahertz, but was the first sterilizable probe in the world. It had a very small footprint, which allowed for intraoperative ultrasonography. And with that, he, predominantly in Japanese language, but he did a lot of the description of intraoperative ultrasound, anatomy of the biliary tree, segmental anatomy of the liver. He described ultrasound guided subsegmentectomy, which in those days, with the then resolution of the machines, was a feat in itself that he was able to do it. He is also responsible for describing the procedures of, Glisonian pedicle injection with isosulfate blue to mark out the surface anatomy of each individual segments. Again, to be able to manage that with the ultrasound technology in those days, almost 40 years back, is truly remarkable. And in 1987, he started describing these other surgeries. Like, for example, he described the segment 7 resection with sacrifice of the hepatic vein while preserving segment 6, which was a first of its kind surgery performed using intraoperative ultrasound to demonstrate communicating veins. So he actually showed the world what can be done with intraoperative ultrasound, and that led to the adoption very rapidly in Europe, starting with Bismuth in 1985, who published his series of ios guided resections. Obviously, Belghiti and Bismuth were professional rivals for a very long time. So it was not, Belghiti was not far behind, followed by Delattre. And then the Italians took over, and then finally the guys from Belgium. So within a span of 2 years, a lot of centers across the world adopted intraop ultrasound to refine their liver work. But this was all in the field of open surgery. It was in the 2000s, with the development of the laparoscopic ultrasound probe, that it got started getting integrated in minimal invasive surgery. And this was first with the Fukuda in Japan in 1984, followed by the Europeans not too far behind in 1989. And then, of course, there was rapid adoption all across Europe, and which led to the International Consensus Conference on Laparoscopic Liver Resection in 2014. Now, before this period, all these publications which are there in the 80s were just diagnostic laparoscopies done using laparoscopic ultrasound probe. Liver resection by minimal invasive technique was still a long shot and very far-fetched, and which is why, it was just an experimental procedure. But a lot of advances rapidly happened with the introduction of the intraop ultrasound, because you have to realize tactile feedback is gone in minimal invasive surgery. You cannot only see the surface, you cannot dissect as well as open surgery. So it required the intraop ultrasound to make laparoscopic or minimal invasive liver surgery possible. And that led to rapid adoption of minimal invasive surgery and the first consensus conference, followed by the second one in 2014. Everybody who is involved in liver surgery is aware of the EVATIC criteria, which lays down the level of difficulty of liver resections. And none of this would have been possible without the introduction of minimal invasive intraop ultrasound. Dr. Go Wakabayashi has described some really complex procedures, and he was the presiding chairperson in this conference. And then came the revolutionary AI integrated advanced imaging by Fujifilm, and I think Miriam has the other software which is competing, although I do feel that the Synapse by Fujifilm is a superior product, where we can make 3D animated casts with location of the blood vessels and the tumors, so as to plan the surgery pre-operatively and then execute the plan intraoperatively using intraop ultrasound. And we will go through this stepwise, but first we need to understand the basics of sonography to do this. Now, putting all this background, we cannot neglect or ignore the contributions of the single man whose involvement in this field has revolutionized how we perform liver surgery, and perhaps his single contribution overshadows all those that I have already spoken about, and that is Dr. Guido Torzilli from Humanitas University. He was the first person to give an in-depth description of intraoperative ultrasound guided liver surgery in the English language in an atlas. Incidentally, if we look at the history, he had trained with Professor Makuchi in the 90s and early 2000s. He was actually the only non-Japanese person to become a professor in the Tokyo University. And he is the pioneer in the scaffolding preserving liver surgery, where we preserve the liver structures so that the liver can hypertrophy after the surgery, and develop the various non-traditional liver resections with in-depth descriptions which make the surgeries truly replicable. He is also the person who devised ultrasound-guided R1 vascular resections, and we will address each of these topics through this entire series of 5 lectures. What about the Indian perspective? The current status of intraop ultrasound, I don't know the exact number of people who use it, but just to give you a comparison, we have 300 robots in India. People are doing robotic surgery on a daily basis, but we have only 45 intraop ultrasound installations by Fujifilm, and which is the leading brand in this product range, and only 30 of them are robotic and 4 are laparoscopic, which tells us the poor adoption of minimal invasive as well as open intraoperative ultrasound in India. Definitely, it's because of a training gap. We as surgeons are not taught in our postgraduate or in our specialty training of how to interpret, how to perform, and how to interpret ultrasonography. To some extent, maybe PCP and DT is responsible for that, but I think it is the onus is also on us to go through the rigors of the training. In fact, intraop ultrasound would tremendously drive cost effectiveness. In a country where you can afford 300 robots, we are not having intraop ultrasound, which makes the surgery much more economical because of improved oncological resections, decreased morbidity, performance of one stage liver resections for multiple liver metastases, and various other innovations that can be founded on the principles of intraop ultrasound. So I think it is on us to increase the adoption of this revolutionary technique, and we should have this vision as a part of the goals of this webinar. So the basic principle of ultrasonography is the pulse echo principle, where we have electrical stimulation of piezoelectric crystals that produces sound waves, which traverse through tissue. Some of it is absorbed, some of it is reflected back, which is picked up by transducers and converted back into electrical energy, which is then interpreted by the machine to give a black and white or a image, which is read by us as the ultrasonography image. The image resolution is dictated by the frequency. This is the single most important principle that we need to know to understand the probes. The image resolution is better with a higher frequency, but higher frequency leads to a lesser depth because the sound waves get absorbed faster and it does not reach the depth of the tissues. So this is one principle that we need to understand for the choice of the probes. Coming to the probes, how do we decide which probe to be used for intraoperative ultrasonography? It depends on, of course, whether it's an open or a laparoscopic surgery, but in open surgery, it depends on the size of the probe, the scanning window, and that scanning, by that I mean the panoramicity that we require for a particular step in the surgery. Adherence to target organ surface. If you have a very large probe and a small organ, the stability to avoid air interposition will not be there, and you would get artifacts which undermines the image that are produced. And the probe has to be a balance between size, magnification, resolution, target organ adherence, and panoramicity, all combined, uh, depending on the step of the surgery. So the commonly used probes are the convex probe. This is the basic probe which is there in all sonography machines, which is commonly used. It's the workhorse in cutaneous sonography. We also use it as a screening mode for starting off the sonography before the mobilization of the liver. It is a low frequency probe, as in the frequency is 2.5 to 5 megahertz, which makes it the depth much more, the panoramicity is much more, and which is why for initial screening before the liver is mobilized, it's a very good tool to understand the basic anatomy and to see whether the imaging that you have done in the preoperative period roughly coincide with what you are seeing inside the body. It is good for visualizing deeper structures like the glycerine pedicles and the veins, the major ones. And it is also good for contrast enhanced ultrasound. And this is, of course, now we have better probes than this, but in the olden days when we did not have dedicated intraop ultrasound probes, the convex probe with low frequency was the one used with contrast. We have to remember that all the probes have to be sterilizable for direct contact with the tissues. And Hitachi Eloquo and hence Fujifilm was the first company to introduce these kind of probes. A lot of companies do have this T probe, which was the common probe that is used. It has its limitations because it's a medium range 5 to 10 megahertz probe. It is high resolution but very low panoramicity, and it does not have the convex array mode. It has a linear array mode, which limits the area of visualization. And hence, it has very limited use for intraocular ultrasonography for during the time of resection. Of course, the best in class probe, in my opinion, for open surgery is this microconvex probe, which was developed again by Fujifilm. And this is a very wide frequency probe with a 2 to 7 megahertz range. It has also got excellent panoramicity. It covers a very large field, and it is a perfect balance for liver sonography because it is a convex probe, so you can just tilt the probe a little bit and cover a much greater area and see relations of the various structures and the tumor nodules without moving the probe too much on the surface. It has this finger grip, which helps the surgeon to manipulate very easily with one hand and just two fingers. And it is the workhorse for ultrasound guided surgery. Of course, for minimal invasive surgery, we have two probes. This is the standard laparoscopic probe, which I feel for at least laparoscopic surgery is actually better than the drop-down robotic probe. It has got a 5 to 10 megahertz range, and it has got both linear and convex arrays. It is very well adapted for maneuverability. The Fujifilm probe has got these two joysticks, which are for the up and down and the lateral movements. It has got excellent panoramicity and ability for both Doppler and contrast enhanced imaging. The only disadvantage is the cost. It's the costliest probe that is available, and it's almost like 5 times the cost of a robotic probe. Of course, the robotic probe, again, Fujifilm was the innovators in this, and it is a game changer in robotic surgery because it can be integrated with the console. It has got very good, it can be put through one of the trocars. It has got a very small footprint. It can be manipulated with the robotic or the laparoscopic instruments. It has got blood flow mapping, which is very helpful, especially since you cannot, especially if you're sitting on the console, and it really helps to identify the structures properly. It can also be combined with laparoscopy by just putting the instrument through the same trocar that the probe is inserted to visualize the liver. Now, we'll go to the technical tips during the surgery for performing intraop ultrasound. The first and I think the most basic foundational thing is the positioning of the machine. In open surgery, the machine has to be facing the surgeon on the opposite side of the patient. That's the most convenient way of knowing how to manipulate the liver and being able to see both the liver and the screen in the same field of vision so that we can conduct it very well. We normally see the sonography machine on the left hand side on the same side of the operator when it is a cutaneous ultrasound in the OPD. That's not how intraop ultrasound machine should be placed in the OT. It has to be opposite to the surgeon. But in laparoscopy, it has to be over the right shoulder because often the laparoscopy is done with the surgeon either on the right side or in between the legs of the patient. And hence, the position that is convenient for the machine is over the right shoulder. So it is important when we are doing the laparoscopy, open surgery, that we should have adequate exposure. And that is because it's not just the sonography that is important. We need to be able to put our hand below the liver to be able to define the planes of resection. And that's where either a reversal or a Makuchi incision really is one of the best ways to access the liver for open surgery as well as for intraoperative ultrasound. So after the initial screening with the convex probe, I think it is worthwhile mobilizing the liver so that we can insert the hand below the liver and the entire liver can be delivered into the incision so that a dedicated and complete intraop ultrasonography can be done. So this is how we start. This is the This is the low frequency probe or the convex probe that is being used. You can see the right hand side of the screen is the depth, and the depth, the gain, everything has to be adjusted so that we can adequately visualize. We always start with visualization of the Glisonian pedicles, and that is done by placing the probe over the segment 4 and 5 of the liver, which you will see. But the problem with the convex probe is that the costal margin comes in the way when you want to visualize the segment 8 or the confluence of the hepatic veins with the IVC. You can see that I'm struggling to go and visualize the IVC and the hepatic veins because the probe is bulky, and you can see the artifacts that are coming in the vision while we are trying to go under the costal margin to visualize the IVC. But this is a very good probe for a basic screening before the liver is mobilized. And you can see some of the lesions appearing while we're doing the sonography. Compared to that, you can see the microconvex probe. It's very convenient. It sits very nicely on the liver surface because the area of contact is low. There are hardly any artifacts because there is no air interposition. We have started with screening of the Glisonian pedicles. You can see there, that's the segment 3 that is going, and that's the segment 2 which will come in the vision. That's segment 2. That's the main left portal pedicle confluence, the anterior and posterior sectoral pedicles there. That's the anterior and that's the posterior sectoral pedicle. And this is a lesion in close contact with G6. Now I go below the costal margin on the dome of the liver, and you can see it's very simple. I'm in complete control. You can see the IVC, the port. You can also just tilt it to see the porta, and that's the confluence of the right and middle hepatic vein with the IVC. Now, if you follow this vein, the right hepatic vein, as it goes, it is between the anterior and posterior sectoral pedicle, which helps us identify exactly, like, for example, now we can see as it goes back, the lesion which is there, and you can use that to segment the liver and to find out in which segment the lesion is located and how to approach this. You can also see this is a segment 2 lesion, which was below the segment 2 portal Glisonian pedicle out there. And that's the confluence once again. You can very well delineate the Linux capsule. This is the structure that helps us perform the R1 vascular resections, where we can peel off the tumor without increasing the risk of local recurrence, because it's a tough layer that helps us do the dissection. The robotic probe can also be used in open surgery because it's a wide array probe. You know, it's from 2 to 12 megahertz range. You know, you can use it to see lesions which are very close to the surface or which are very tiny, because the magnification and the resolution can be changed to ensure that we can access those lesions or lesions which are not easily picked up by the other probes. So you can see again that same lesion which we had seen on the microconvex probe, much better resolution. You can see that the portal Glisonian pedicle is compressed out there over the lesion, and therefore it will involve ligation of this Glisonian pedicle to remove the lesion completely. So these finer details can sometimes be very well appreciated with the robotic probe. This was one other lesion where I was getting an artifact with the microconvex probe. So we are using this robotic probe to delineate whether it's just an artifact or whether it's actually a lesion that needs addressing. For the laparoscopic sonography, you can see the sonography machine is at the head end of over the right shoulder of the patient. You need the screen, the laparoscopy screen, as well as the sonography screen in the same field of vision to be able to understand where we are looking at. So this is a segment 7 solitary metastatic lesion where we are doing the sonography to delineate the structures and relation to the other Glisonian pedicles so that we can do the intraoperative marking, and perhaps in one of the sessions we will show the complete video of how this was done. But you can see that somebody needs to do things like freezing the image, storing the images, changing the gain or the magnification. It can be, we can put a sterile sheet over the console of the sonography machine, and assistant or the surgeon can do it, or you can have somebody in the OT to do it for you. Now, what are the clinical implications? What we see is that, we have these very complex descriptions of how to do the hilar plate dissection to identify the sectoral pedicles, then loop them, and then give block them and give ICG for negative staining, which is like a 2-hour process to identify the segment of the liver, which can be done by just placing the probe, which replicates the exact same anatomy as you can see out here, just by putting the sonography probe. This gives us a lot of anatomical decisiveness of the location of the different structures and how to go about performing a parenchyma sparing surgery. You can do like marking in real time, so you can see the left hand of the surgeon is so that's the my hand below the surface, and if you see the screen, I am pressing the liver with the finger so as to identify the the line of resection in context to this image that is seen just next to the finger. That is a very good way of identifying the direction and the line of resection, so that we do not get R plus margins, and we can identify even deep seated lesions. It helps us deploy very complex parenchyma sparing strategies. Like, for example, if you see this, this is actually a physiotherapist in our hospital who had colorectal liver metastasis. You can see the blue liver, so received a lot of preoperative chemotherapy because these lesions were in direct contact at the portal confluence. This patient is not for a right or a left or a central hepatectomy because of the location of these lesions in contact with the Linux capsule. And as we discussed while we are seeing the video of the Linac capsule, using R1 vascular principles and using intraoperative ultrasound, you can do conservative resection, remove this disease while preserving the Glisonian pedicles. This patient went on to live for another 4.5 years, had another liver resection, and then died of brain metastasis. So you can, from a completely inoperable patient to a patient who is surviving for 4.5 years, that's the impact of intraop ultrasonography. It also helps us deploy certain other things, like, for example, this patient is a 78-year-old patient with NASH with a 8-centimeter HCC, so not suitable for transplant, not suitable for a right hepatectomy, and involving the right hepatic vein, which you can see is resected out there. Yeah, but we are still able to preserve segment 6, 5 and everything because we identified this communicating vein between the distal part of the right hepatic vein and the middle hepatic vein. Communicating veins are present in almost 80% of the patients with compression of the vessels. They open up in response to involvement of a vessel by a tumor and can be used for parenchyma sparing strategies. This patient was operated 4 years back and continues to be in remission till date. It sometimes also helps us identify lesions which are not picked up on preoperative imaging. Like, for example, in this patient where we can see a segment 8 lesion, which was identified in addition to the posterior, segment 7 lesion, which helped us modify the surgical strategy to extend the resection to segment 8 instead of just a posterior section. And in fact, it can lead to several new types of resections. You can see the upper transversal hepatectomy, the vascular recons that can be done for the hepatic veins to preserve the supply, and various other relatively undescribable surgeries that we can do. Essentially, it changes the strategic outlook of how we approach liver surgery and what is possible in terms of resection of the liver to remove all the disease while preserving adequate liver function in a single stage surgery, which is very, very important. So I'm coming to the end of this talk, and I think I would like to leave it with this concept. I often use this slide. I think it's a very profound statement that simple can actually be harder than complex, and that you need to clean up your thinking, simplify the concepts, and then you can go on to do magic. Thank you very much, and would be happy to answer any questions.
Thank you so much, sir. Do we have any questions? If someone wants to ask a question, we can unmute the person also.
So while we are waiting for questions, I think what I can do is I can lay down what we are going to do over the next 4 sessions. In the next one, we will also be looking at how to apply these principles to identify the normal anatomy of the liver and how to use that to again, plan to see the relationship of each of the individual lesions in relation to the normal anatomy and how that impacts surgical planning. We'll be looking at that from both the open as well as the laparoscopic point of view. We will probably show some videos of how it is done in real time in the surgery. The next one, we will deal with the concept of Synapse 3D and how we use preoperative planning to make plans preoperatively and then conduct those same surgeries intraoperatively. And following that, we'll do some case studies of some complex resections that we have performed to see how surgical decision making as well as this new approach helps us deliver outcomes for our patients. So one of the questions is how can we combine intraop ultrasound with ICG? That's a very important question. I think while intraop ultrasound gives us the maneuverability and planning, ICG can be used for vascular supply. It can be used once the resection is done to look for any bile leak by injecting it directly into the biliary tree. ICG is very, very useful in laparoscopy, especially when we are operating for HCC. It helps us detect those lesions and helps us perform those resections with a greater deal of confidence, especially in cirrhotic patients. And while those two modalities are not used together, I think it would definitely adds value to the safety of the surgery.
Hello.
Yes. Yes, Dr. Ramakrishnan. Hello. Rhythm. Hi.
So
Hi, Rhythm.
how you were teaching? Hi, sir. So, one question is, how do you decide on the frequency? Means first you are using the convex probe, then you are using the convex probe, and you change some frequencies over time. So how you decide on that?
So the it's a very simple concept. Higher the frequency, lower is the depth of penetration. So if you are using a convex probe, it is a low frequency probe. So the depth and panoramicity is more. So you can see the deeper structures well. It's used for, like a screening process when the liver is not mobilized. Sometimes you open the abdomen and you're not very sure about operability. So you would do just a basic screening without trying to mobilize the liver. And if you feel that, surgery is not to be conducted, you can abort without doing too much or mobilizing the liver or doing too much damage. It's also helpful in certain patients where the diaphragm is invaded by the tumor and you cannot mobilize the liver well. There, I think convex probe with lower frequency and therefore a higher depth of penetration is useful. In the microconvex probe is a wide range probe which has both it's a low as well as high frequency, but in the mid range, and that is very useful for visualizing 1 centimeter down, meaning the upper 1 centimeter of the surface is not very well visualized by the microconvex probe. You can sometimes miss small lesions there, but those are palpable. So if you're doing an open surgery, it does not lead to a lot of detriment, which is why I said that the microconvex probe is actually the workhorse. Uh, and if you really want to visualize superficial lesions or characterize more the lesions which are slightly deeper seated, then the robotic probe does an excellent job in combination with open surgery microconvex probe.
Okay,
So that's
got
how
it.
you select the probes. Higher
Got it.
frequency, lower depth. That's the rule.
Okay, okay, sir.
So Dr. Akhil has raised a question. Is there any role of using Doppler mode in intraoperative ultrasound for looking at portal blood flow in the remnant liver prior to going for definitive resection? Yes, so the Doppler mode is definitely used, and we will see that in the next session when we show the normal anatomy of how the Doppler mode is used. We'll also, define the basic principles of Doppler, as in how, the colors of the Doppler are not related to artery and vein. It is the direction of the flow and how that can be used to identify the vascularity. So that is going to be one of the topics of the next session. There is another question.
Yes, sir. Before that.
Which one is that? How will you differentiate portal vein branches from hepatic vein branches? Yes, again, we are going to see that in the next session where we are going to define the normal anatomy on intraoperative ultrasonography. However, if we see some of the videos that I showed today, the Linac capsule is much thicker around the Gleasonian pedicle or the portal pedicle. Also, you can see the the Mickey Mouse appearance where the face of the Mickey Mouse is the larger. I can perhaps show one of those. So the face of the Mickey Mouse is the larger portal pedicle, and just one minute, this one, yeah. So this is the Gleasonian pedicle. You can see the thick fibrous layer, and you can see this. This is the hepatic artery. And if you see this in a cross section, it appears like a Mickey Mouse face where you have so just there, maybe I can, 1 minute, I think. So the artery and the vein. So this is a Gleasonian pedicle, a thick fibrous layer, artery and portal vein. Often you cannot identify the bile duct. Again, this is also a Gleasonian pedicle. You can see the portal vein and so this is a subsegmental branch, which is the portal vein and the hepatic artery. So that's ways. Whereas if you see the vein, 1 minute. So the vein is very thin mold like this. You can see this. This is the vein, and it is a single structure. There will be tributaries joining it, but it is a single structure and does not have a thick fibrous layer around. So this is the IVC. And this is the portal pedicle again. You can see the thick fibrous Linac capsule. And this is the vein. The vein, these are venous tributaries. You can see very thin walled, no fibrosis around the capsule, around the vein, sorry. Does that answer your question, Dr. Ramakrishnan? So the next question is, which technique you use for increasing the FLR? So let's put this into perspective. FLR is very rarely used for hepatic metastasis. Majority of the times with chemotherapy response, in almost all patients, you can do a parenchyma sparing surgery. Very rarely do you need to do standard hepatectomy. If a standard hepatectomy needs to be done, it's usually for HCC or for cholangiocarcinoma. And in that situation, we usually use portal vein embolization very liberally, especially if you are like in an HCC, if you want to do a laparoscopic liver resection, then doing a TACE followed by portal vein embolization makes that surgery safer and more possible with a decreased risk of postoperative liver failure. And it also tests the biology of the disease to let us perform the procedure. In cholangiocarcinoma, almost all patients with a type 3 and above would need a portal vein embolization. We will also learn about calculation of how to go about calculating the FLR using the Synapse 3D software. I think the best job is done by the surgeon rather than a radiologist. And I think the whole concept of referring a patient to a radiologist for calculation of FLR is flawed. And we will see why that is the case with real examples. This will be in the third lecture.
So one more question, how IOUS will be used for other organ cancer? And
Oh, sorry.
what other system can be used when Fujifilm system not available?
So I think BK Medical, Isaote, and Fujifilm have the widest range of probes which can be used for intraoperative ultrasound. Most other systems have got the T probe, which is a very basic instrument which can be used. They also have the hockey stick probe, which is very unwieldy. I really don't see any value in it, but sometimes you can use that. Otherwise, you can just use the standard convex probe. In the systems where intraop ultrasound is not dedicatedly made, barring these three companies, what also happens is that none of these probes are sterilizable. So you have to use it with a camera cover and a glove, and then you can have air artifacts or decrease in the resolution because of that. So I really feel that if you want to do a good job, the Fujifilm or BK Medical or is out here. These are the three main companies which make the best quality machines and probes. Other organs, of course, it's also widely used in kidney now with the advent of the robotic systems and the robotic partial nephrectomy. I think we can increase the range of partial nephrectomy, or rather increase the number of patients that can benefit from a partial nephrectomy by using these intraop probes, which can help us identify deep-seated or endophytic lesions, or sometimes in VHL patients, multicentric tumors within the kidney, where you can do a minimal invasive partial nephrectomy, or even in open surgery for endophytic lesions, the robotic or the microconvex probe can really help, and we have used it often for that. Also, sometimes it can be used for metastatectomies in the lung, although it's not as performant for the lung as the liver and kidney, but it can sometimes be used. And I think the CVTS surgeons also regularly use it for during valve replacement surgeries and pediatric corrective surgeries. It's also used in neurosurgery very commonly, and I think, if I'm not mistaken, some of these probes originated by first being made for neurosurgery and then their use being adapted in the abdomen.
No more further questions, sir. Thank you, sir, for an inspiring and insightful session. We appreciate everyone's enthusiastic participation and thoughtful questions. As Dr. Mehta already mentioned, this is just the beginning of 5-part series. Our next webinar will dive deeper into liver anatomy on IOUS, both open and MIS. So stay tuned and continue to register through Skill Club platform. Thank you once again for joining us tonight. Have a wonderful evening.
Thank you. Thank you.
Thank you, sir. Thank you very much.